Everyone, can you all hear me? Yes. I am quiet sometimes, so if you can't hear me at the back, please just tell me. So yeah, I'm Kayleigh. I've worked with the pain team for about 5 years now. So I'm going to talk to you about what we do, okay? Little switch and focus. I'm doing a little bit more into acute pain because there's a lot of the chronic pain stuff going on, but I will talk a bit about the clinics and stuff we do. And by the way, I use clip art. I don't have the fancy stuff Renato did, so I'm sorry that it doesn't look as nice. So as Dr. Ashatha said at the beginning, we're quite unique in the fact that the nurses, we work both inpatient and outpatients, okay? So a lot of different hospitals have separate services. We have integrated and we work in both. All the nurses, there's 4 of us. We kind of share all the jobs pretty much between us. We take it in turns to do different things, so we can all do everything, okay? So on the inpatient side, we see patients on the ward, so we get referrals from the whole MDT, nurses, doctors, physios, anyone who's seen a patient in hospital who they think they're struggling with pain. So they can refer to us on our computer system, or we carry a bleep, so it can just be ring us, let us know. But we see both acute and chronic pain patients on the wards, okay? If we are particularly struggling with a patient, if there's something quite complex or we're just not sure we're on the right track or want some backup for we are on the right track, our consultants do ward rounds with us during the week. We identify which patients we would like them to see and they come and give their advice. We do all the pain education in the hospital, mainly for nurses, but other members of the MDT, and once a year the anaesthetic juniors, we teach them how to use our pumps, and we go through that. So that's kind of more the inpatient stuff. Outpatient wise in the clinic, so we've recently in the last year started doing telephone follow-ups for post procedures and post lidocaine infusions. That's nurse led now, okay, the follow-ups. The consultants identify who they want us to ring. We run the Cadenza clinic, so Dr. Ashatha mentioned that it's the capsaicin, the patch, the high dose for localised pain, so a localised neuropathic pain. They have to come into the clinic. That sounds very rude, the patient has to come into the clinic. Something that has to be done in a specialised setting, can't be done in the community. And that's every 3 or 4 months, the treatments for each patient, so we run it twice a month. We've just started in April our nurse-led IV lidocaine infusion pathway, so that the patient will be put forward by the consultant. This is suitable for you to have a lidocaine infusion. We run the first one. Our consultant will consent the patient to have 4 individual lidocaine infusions. The follow-up will be 10 weeks later. One of us nurses will phone, do the follow-up, if suitable, back on, carry on for the rest of them, okay? Won't need to see a consultant in that time during that, for that particular pain, okay? And we also assist the consultant when they do their procedures, the injections, the trigger points, all the stuff that's been mentioned, okay? So quite a wide variety of stuff that we're going to do. Or that we do. So I'm going to talk to you a little bit about acute pain and the pain that we do in the hospital, okay? So pain in the hospital, so pain is one of the most common reasons that people come to A&E, okay? Whether it's they've broken something or something hurts, they come in, okay? Which I think is understandable. You don't go in unless there's something wrong. Pain is a big sign that something's wrong. So in most recent statistics I've seen, 1/3 to 1/2 of people in the UK suffer with chronic pain, so that's around 28 million people. So if 1/3 to 1/2 of people coming into hospital have pain, that's a significant number of people. We know that patients with chronic pain, they see their GP more frequently, but they're hospitalised nearly 3 times more often. Okay, so again, when we go onto the wards, we see a lot of patients who have these chronic pains and are now in hospital for whatever reason, okay? So, and then just a few about painkillers. So there's a lot of money spent on analgesia and a lot of prescriptions being handed out every year, okay? So if someone is already on these, it then can make things more difficult when you come into hospital to manage an additional pain, okay? Because there's already a lot of painkillers out there that people are taking, okay? So I keep saying we're seeing acute and chronic pain, and I know Dr. Ashatha said earlier, so acute pain, less than 3 months, something that's new, okay? Caused by surgery or trauma, mostly, okay? So obviously if someone has fallen over and broken their hip, that's an acute pain, or we've given them done some surgery, it's going to hurt, that's hopefully going to be an acute pain. Chronic pain, as we said, lasts longer than 3 months, okay? Can be caused initially by the surgery, by the trauma, by a disease, okay? Diabetic neuropathy from diabetes, quite common. Or it can be unknown in certain cases of chronic regional pain syndrome. We don't know what the cause is. It can happen, and then we have to manage it, okay? Acute on chronic pain. So this is another term I'm going to throw out there. So this is an increase in someone's chronic pain. So an increase in what they normally feel on a day-to-day basis, okay? We can call it a flare-up, okay? So it's a flare-up when there's no reason why the pain is getting worse. We can call it a flare-up, okay? Or it can be a new pain in addition to the chronic pain, okay? So someone having hip surgery, but they already have arthritis, okay? Or back pain or something. So you're having something that's causing pain on top of something that already hurts, basically, okay? We call that acute on chronic pain, all right? So what do we do when someone is in hospital with any of these 3 things, okay? I'm not going to talk so much about what we do for the chronic pain, okay? But I'm going to talk about what we do for the acute pain and the acute on chronic pain, all right? So mostly we optimise pain medicine, okay? So on the wards, someone comes in, they're in pain, doctors have prescribed their whatever they've prescribed, and patient's still in pain. So most of the time it's the nurses who will call us. Sometimes it's the doctors and say, we don't know why we're not on top of this person's pain. Can you help us? What do we do? So we will go and review, we'll talk to the patient, you know, go through probably with more time than on a ward round, okay? We will have more time to sit and say, what's caused this pain? How long has it been going on for? When did it start? What have you tried? What's helped? What's worked? What hasn't worked? And then we can go through, what are our options left? Where do we go from here? What do we do medication-wise, okay? It might not be medication, it might be that actually we need to increase a bit of physio if it's after an orthopaedic surgery. Actually, lots of painkillers are only going to do so much, okay? We've got to balance those side effects with actually getting you moving and kind of getting back to how you were before coming into hospital, okay? And then in more acute cases, so PCA I'm going to talk about in a minute, and epidural, these are interventions that we can offer for acute pain, okay, along with nerve block and wound infiltration. So epidural, this is different to, well, goes into the same place, but we use it differently to those when patients are in labour and the one-off injections for when you have them for chronic pain, okay? So it's an infusion that we can run for 3 days after quite big surgery, okay? Normally we do it for big open abdominal surgery, okay? Obviously it can be quite painful. So it runs with local anaesthetic and an opioid called fentanyl, or we can run it with local anaesthetic on its own, okay? And it's just to really get over that initial post-operative period, okay? That bit that's really going to hurt. Everything's all about enhanced recovery now. We've got to try and get you up, get you moving, get you eating, get you, you know, doing everything because we know that that's better for your recovery. But if it hurts, you're not going to move, okay? So we try and kind of introduce this as something that can help with that initial post-op period without using such high doses of opioids, because we know that they all come with horrible side effects. The nausea, the vomiting, the constipation, the drowsiness, all things you don't need when you're already unwell, okay? And that's one option. So I haven't got a picture for this one, sorry, but there's the same pump that we use for nerve blocks or wound infiltration. So we're most commonly seeing wound infiltration for mastectomies that involve a procedure with an LD flap. It's a type of reconstruction, which can be very painful. The muscle here is kind of brought round to do the reconstruction, so there's a lot of pain kind of around the back. So this is a local anaesthetic only. We run it for 3 to 4 days, again to avoid additional opioid use. Okay, anything to avoid using opioids that's going to have side effects, we will try. Okay, and then during surgery, anaesthetists choose to do one-off blocks. Okay, a lot in orthopaedic surgery. I think most commonly we see for hips, they use a nerve block for hip surgery. Okay, but they're one-off. They don't run as an infusion, but they can help with that initial 12-24 hours post-surgery, having that extra bit of pain relief. So most commonly out of all of these is probably PCAs that we'll see. Again, post-surgery, post-trauma, doesn't necessarily have to be post-surgery. If someone has had a big car crash and they've broken lots of bones, we can use this. Exceptions would be something like sickle cell disease, which we do see, which obviously there's no surgery, there's no trauma, but in a crisis, very, very painful, very difficult to get on top of the pain, we can use a PCA pump. So basically what it is, it's a syringe that has most of the time morphine or a different opioid in it, and the patient gets a button and they press the button every 5 minutes and they give themselves a shot of morphine. Okay? It's a strong dose, which is why we only use it acutely for short periods. But it's quite safe. It has a locked period. You can't overdose on it because it's locked. You can press the button as many times as you want, but you're only going to get it within certain parameters. Okay, it's not an option for chronic pain because it's such high dose, and you know, where's the end point? We have to have a kind of cut off at some point. So if it's post-surgery, we can say, okay, managing the surgical pain, then we come off of it and we give other painkillers. Okay. So that is an option for us, particularly if someone has, you know, lots of pain history. You know, they're on painkillers already. We know that having some additional pain is going to cause problems. This is an option. Okay. So acute on chronic pain. So just kind of gone into a bit more here. So a new pain on a background of the chronic pain will increase how bad the chronic pain is in most cases. Okay, so if you fall over and you hurt your arm but you've got arthritis, it might flare up all your arthritis. If you break your leg and you've got neuropathy, it's probably going to increase the neuropathy as well as the acute pain from the break. Okay, so it can make both pains more difficult to manage because we're now dealing with two different pains. Okay. So what we do is we work with our ward teams. We do lots of trial and error, unfortunately, in pain management. You try one thing, see if it works. If it doesn't, we try something else. Adjusting the doses to try and get to a point where we can manage both of these pains, okay? The aim is to get pain down to the baseline pain, okay? If someone has chronic pain and they've come into hospital with a flare-up of this pain, we are not going to treat and cure this chronic pain. It's getting the pain back to normal, and I say normal because what is normal, and that will depend on the person, okay? We have developed how to manage flare-ups leaflet because we do see quite frequently people get increases of their normal pain for whatever reason, so we're kind of developing how to manage that, so you don't have to come into hospital and be, you know, put out there in the hospital bay that's noisy and infection and there's lots of stuff going on all the time and no one wants to be in hospital if they can help it. So we just spend time going through how do we manage this, what do we do in the future, do we need to change the medication? If we do, we can contact the GPs, this is what we've done in hospital, this might be worthwhile, you know, when you go home, to carry on taking that if that's helped. So yeah, we do our best with what we're given resources wise, okay. Yeah.